Sir, I truly appreciate your dedication. Thank you very much for joining today. I know it must have been so late for you to join. Really grateful to you from the depth, from the very depth, because I know this is all your dedication. First of all, thank you very much for accepting an invitation to deliver your lecture. You are an inspiration, and I've been actually working on, like I told you, in one of my papers, and I came across your papers again, and it was so wonderful. So your work is so amazing and very inspiring, especially for young researchers like me. So, sir, thank you very much. I'm so overwhelmed with joy and honor to welcome you today and to have you arrange such a special arrangement to make it possible for us to have the opportunity of listening to you. So, thank you very much.
Okay, perfect. Okay. So let me know when we can start, so I can start with the presentation, and hopefully the sound is good.
So everything is so perfect. Please proceed with your presentation. I'm just recording it on my computer now, so you can just proceed and take as long or as short as you like, with whatever duration, because it's totally flexible. So thank you very much, sir. The floor is all yours. Just proceed with your lecture. Thank you.
Okay. So thank you everyone, and thank you again to Dr. Noor for this kind invitation to participate in these webinar sessions. Uh, my name is Andres Rubiano. We are going to speak today about the intracranial compartment syndrome. We are going to focus on how we are shifting paradigms from the traditional concept of intracranial hypertension and how we are using this new approach in order to tailor diagnosis and also tailor um, uh, we regularly do with the NIHR Global Health Research Group on Acquired Brain and Spine Injuries through our research centers in Colombia Meditech Foundation. So the objectives of the lecture will be three. The first one will be to define the origin of concept, the intracranial compartment syndrome. The second one will be to discuss the relationship between the intracranial compartment syndrome concept and the Monroe-Kelly 4.0 paradigm shift inside the new framework for neuroworsening. And the last one will be to present a new framework for surgical decision-making according to the intracranial compartment syndrome concept. So let's move to define the origin of the concept intracranial compartment syndrome. So in order to go to the details of the concept, we need to start from the beginning And when we talk about intracranial pressure, we regularly move to the University of Edinburgh in Scotland in 1726. And we arrive to these days because of Alexander Monroe. So we all know the initial concepts of Monroe and how he approached at that time, without all the technology and only based on observations, especially in cadaver specimens, how they approach the dynamics of the content inside the intracranial ball. So we are all familiar with the Monroe-Kelly doctrine. It was presented at the end of the 18th century, and Alexander Monroe and his mentee George Kelly described the intracranial dynamics in the next aspects. They mentioned that the brain is enclosed within a non-expandable box of bone. The brain parenchyma is practically incompressible. The volume of blood in the cranial cavity is almost always constant, and a continuous outflow of venous flow from the cranial cavity it is required to make room for a continuous inflow of arterial flow. This was presented posteriorly by John Abercrombie, who was the mentee of George Kelly, and he described that in 1828. It is important that we take into consideration that with this original description of the doctrine, they never mention specifically the role of the CSF inside the cranial ball. Then we moved to the Lund University Hospital in Lund in 1971, and we arrived there because of the work of Niels Lomberg. We are all familiar with the activity and the proposals of Niels Lomberg being the pioneer of evaluating CSF pressure inside the ventricle area. So we start implanted small subdural or epidural transducers and also doing some evaluation inside the ventricles for the CSF pressure. So in the original descriptions, he presents how in the progress of many of the patients with severe TBI especially, the behavior of an important type of measurements was presented with a specific pattern of waveforms. We need to understand that what Lomberg see at that time or saw at that time is not the same waveform that we saw actually, because the system that they use, it was almost like an EKG system of the same that we actually use today. So he see the waveform analysis in big periods of minutes and sometimes even hours. What we look actually today is only waveforms in milliseconds or seconds. So he described the three patterns that we classically understand: the type A waves, the type B waves, and the type C waves. If we want to know a little bit more of these details, what they do was the type A waves show the most substantial increase due to the sharp static over sloping, at least for 5 minutes. He saw how they decreased to normal levels and how the patients were presented with headache, nausea, following by stupor and tonic posturing of the extremities, often with clonic convulsive moments. So he was evaluating patients with reduced compliance in the process of brain herniation. So what we saw with the type A waves are actually the manifestation of the brain herniation process. Then he described another type of waveform that was so-called the 1-minute wave, type B. There were increases of pressure up to 50 millimeters of mercury with hyperapnea and restfulness. So this is the traditional presentation of an elevated ICP. And the third waveform of increased ICP was the 4 minutes wave, type C, which was often observed with a marked increase on ICP changes in brainstem function. So these waves are considered normal interactions between the pulse and the respiration. All this was presented by some of the papers of Lomberg, and this is specifically one published in 1965. Then we moved to the Institute of Neurological Science in Southern Hospital in Glasgow. Around the same time, following the same structure of analysis that Lomberg performed, the group of Glasgow was evaluating also measurements in these patients. So we have here a historical picture of the inaugural staff group being Wilder Penfield, very well known for all the localization and anatomical and functional descriptions, he was the first chair of the service. We also have in this picture Graham Tisdale and Brian Jennett, who are the persons who describe the Glasgow coma scale. So following Lumber's work in this group, they define the normal ICP as below 20 millimeters of mercury. They also discuss the association of high ICP with low CBF and low CPP. They were describing how this is associated to at least a decrease of 30 to 40 millimeters of mercury in CPP. We need to remember that in Glasgow, they have a very well organized following of the patient by the nursing group. And it was how they approach and correlate all these clinical variables with the CT imaging, because Glasgow was the first institution that have access to a CT in that time. So we have these original pictures of Godfrey Hounsfield with the system and how we have this very full of pixels image of the first or early cities. Then, following this historical vignette, we moved to Virginia Commonwealth University at the main hospital in Richmond around the same time. And many people start working on something that was posteriorly used, like the subarachnoidal Richmond screw. So it was designed by Tony Marmaru, who was an engineer, working with Donald Becker and J. Douglas Miller. We need to remember that Miller was also from UK. He was originally trained in Edinburgh. And posteriorly, Ross Bullock, who was a trainee of Graham Tisdale and Brian Jennett in Glasgow, arrived and created this group, very pioneering many of the neurotrauma science in North America. So they follow the same principles that was originally described by Lumber, and what they made was start measuring the ICP in the subarachnoidal space through this screw. So in this brief process, we understand how was perceived the concept of intracranial pressure with these persons. So we arrive to the regular concept since the original description of Monroe and Kelly, with all the knowledge that was gained through Glasgow, through Lund, and through VCU, in order to understand how the mass that occupy or lesions that occupy some space inside the skull generate some alteration in the dynamic. And originally the dynamic was the interaction between the brain parenchyma, the blood at venous level, at arterial level, and the CSF. And this is how we arrive to the traditional Monroe-Kelly approach. Around 1980, in the hospital of the University of Pennsylvania, Thomas Lanfield was one of the pioneers using the parenchymal monitoring systems. So they started using these systems, and because of that, they were able to arrive to the very early analysis of the volume pressure curve that was originally also known as the Lanfield curve. So what Lanfield did was understanding that in this relationship between the pressure and the volume, there are some specific areas where minimal amounts of volume generate important changes in pressure. So there were some stages that was described at that time of low compliance, high elastance, and high compliance, low elastance. So this is how we arrived to meeting the pressure volume curve concepts with the Monroe-Kelly homeostasis, understanding that something needs to get out of the skull in order to gain a space for increasing the lesions, being edema or a mass lesion, and how there are specific moments where this can go for very increases of ICP. We have some of the most common persons using this system at that time. We have many of the first systems that were used for measuring parenchymal monitoring, like the Camino system, the ICP Express system, and the Raumedic system, was very used at the time in areas like the University of Cincinnati with Professor Narayan, the University of California, San Diego, with Dr. Lawrence Marshall, the Hospital Valdebron in Barcelona with Dr. Juan Sauquillo, the University of Cambridge with Professor Picard, Dr. Hutchinson, and also Dr. Menon, and the Baylor College of Texas with Claudia Robertson and Alex Balatka. So the group of Glasgow continued using this new technology, and in 1983 they published one of the very early descriptions of the waveform analysis with this new system. So if you see, the analysis of the waveform changed totally from the original description of the three pattern of waves from lumbar to the original three-peak waveform that we regularly use. So now we understand, because the waveform is very reduced, in milliseconds, that we have a pattern where the main peak is P1, that it corresponded to the arterial pulsation. We have a very low pulsation, or P3, that is associated with the venous pulse. And then we have P2, that is what we understand as the waveform for the compliance, that really is associated to the pulsation of the CSF. So we have the three main components that are dynamic. We can start digging into the dynamic inside the school, understanding that there are some elements that are considered static elements, and in this case is the brain tissue, and there are some elements that are considered dynamic elements because move around the structures, and in this case is the pulsation of the venous outflow, the arterial inflow, and also the pulsation of the CSF in the subarachnoidal space. So from those very beginning descriptions, they understand that if you start increasing the pressure, the waveform turns into a pyramid aspect, where initially the P2 or the CSF pulsation goes over the P1 or the arterial pulsation, and then all the waves disappear and turn into a very specific peak design waveform. We can see that in the slide, how the waveform transform into the regular P2, P1, P2, P3 structure to a just one only peak waveform, especially when the ICP goes over 30 millimeters of mercury. They start doing some analysis with the therapies that were associated at that time, like the main therapies for treating these patients. So we have here a patient with three interventions. The first one is hyperventilation, and you see how a waveform that was around 20, 25 millimeters of mercury with the three peaks, P1, P2, P3, then decrease in an important way around 10 millimeters of mercury after hyperventilation. Then you have a waveform analysis with hypovolemia, and you see how the hypovolemia in a patient that have, in this case, around 10 millimeters of mercury, start generating an increase on the ICP up to 20, and how the waveform start changing for the three peak to one that is turning P2 over P1, like in association to the compliance affection. And then there is another patient when you have like the regular three peak waveform, P1, P2, P3, around 20 millimeters of mercury. And then if you elevate the head, then you have a decrease in the number of the ICP of around 10, but there is no many changes in the waveform. So with these original activities and interventions, we are talking about 1980s, they understand that there were some form of decrease the ICP, but not really overchange the waveform pattern. We have here a more specific graphic when you see one of a patient that have around 15 millimeters of mercury with a P2 over P1 waveform. That means a patient that have issues with the compliance. They remove CSF and the ICP comes down around 8 millimeters of mercury. But if you see, the pattern of the abnormality of the waveform remains the same. What does mean? That these were treatments that decrease the number but do not improve the compliance. And this is something that now is very important for how we treat these patients. So you can see there another cases of patients who were hyperventilated and some patients that become hypotensive and how hypotension was associated to increase of ICP. So since then, we understand these abnormal patterns and how they evolve and how if we correlate this with the Lamb-Fit curve, there is a specific moment where the relationship of the curve change and is the moment where small changes in volume generate big increases in ICP and how the um, parameters and um, a structure of the waveform change in an important way and how from the regular P1, P2, P3 structure, then the P2 is going up. And then if you increase more, you move into the one pyramidal way. That is the worst scenario that we can have for a patient that is evaluated with ICP waveform analysis. So the main important point here is to differentiate how Lumber see that at that time, the type A, B, and C waveforms with the regular that we saw right now. So you can see here the differences. It's totally different. And now many of the original description from Lumber really didn't apply too much to what we do now, except when we do all these continuous monitoring and recording with several devices that are integrated sometimes in a specific software that can allow us to see the trend over the day in very long periods of minutes and even hours, so we can identify the original Lumber waveforms. So moving into the ICCS concept, we can understand at that time that there was descriptions originally from these groups talking about differentiation of pressure inside the cranium. So we have here a publication of a group in Virginia that in 1982 were analyzing a patient monitorized in both hemispheres. So they put two catheters. In this case was Richmond subarachnoidal screws, and they saw how the pressures in the right side were lower than the pressures in the left side. And because of that, they describe this phenomena as a intracranial differential pressure. They see that very often in patients with mass lesion that were monitored with these subarachnoidal screws. But at that time, they didn't dig too much into the concept. Then we have more publication, in this case of the VCU group with J. Douglas Miller, when they start analyzing the same pattern. They have patients with a ventricular catheter in one side, with a parenchymal catheter in the other side, and they saw differences in these gradients of pressure. So they describe that as differential intracranial pressures. This was also described posteriorly in other specific case reports. Then the concept was moved to interhemispheric pressure gradients in severe head trauma. We have this publication for a group in Basel, in Switzerland, in 1998, where they see this differentiation of pressure in both areas. So the group from Barcelona also described this in 1999, and they were asking if this was clinically important. They say, okay, we have these interhemispheric supratentorial intracranial pressure gradients in head injury patients, but do they mean something? Are they clinically important? So moving now into the modern area, we now have so many different tools that allow us to understand better what is happening inside the school. So we now have integrated non-invasive systems plus the invasive systems, and we can have a better picture of what is happening inside the school. So when we start using many of these integrated devices, we are talking about 2014, we start evaluating patients since the very beginning, arriving at the emergency unit, and we start using all these non-invasive tools like the pupillometer, the optic nerve ultrasound. Then we compare that with the CT findings, and then when we move the patients either to surgery or to the ICU, we continue integrating this with invasive systems. So we start seeing different patterns, and we start asking what was happening with these patients. So we have this example, for example, some of our patients, we have this patient with an ICP of 12, but with a very abnormal uh, associated to alteration in the compliance patient. So we have the P2 over P1 very clear there. We have also the opposite cases. In this case, a patient with an ICP of 25, but with a regular waveform with the three peaks. We have this case a patient with 18 of ICP with a very abnormal, just one shape pyramidal waveform that we understand that is a very critical waveform because that means that your patient is very affected with that pressure. But the interesting thing here is that at that moment, all that was defined only by intracranial hypertension. But if you went into the original description on how the thresholds evolve, would you never consider an intracranial hypertension with a value less than originally 20 to 25th, and in this case, after 2016, with the BTF guidelines around 22 millimeters of mercury. So we were seeing patients with a normal ICP, but with a very abnormal physiological pattern of waveforms, telling us that the compliance in those patients were very affected. So we start doing also monitoring bilateral in the left and right compartments, and we start seeing also those different that were described originally, like the interhemispheric pressure gradients. But for us, were very significant because we also see the analysis of the waveform, and we also see how this was behaving different with the non-invasive system. Like, for example, in the area that was most affected with the P2 over P1 waveform, we also see a bigger diameter of the optic nerve. We also see a reduction in the contraction velocity with the pupillometer, and sometimes we see increases in the index pulsatility or the pulsatility index and the flow velocity decrease in the transcranial Doppler. So for us, was very clear that that compartment was very affected, not managing very well the dynamic, but the ICP was normal. So we understand that inside each one of these compartments, we have the same structure. You know, you have brain tissue, we have blood vessels, and we have subarachnoidal space. So we continue doing our analysis, and then we start also monitoring oxygen in these patients. And we understand that sometimes patients, even with appropriate considered values of thresholds of ICP, were concurrent with all these abnormalities in the non-invasive system, but also in some cases with low oxygen. And we are not talking here about systemic issues. We are not talking here about patients that have pulmonary problems or ventilatory problems or were anemic or were, no, we are talking patients that were with all the aspects or the patterns that influence oxygenation in general in a normal way, but the oxygen at the brain level, at the brain tissue, was very affected, and we didn't understand why. When we start treating some of these patients surgically, we saw that in some cases, as soon we treat the problem of the compliance, the oxygen start going up. So it seems, because all this was observational, that sometimes the affection of the compartment in the compliance also affects, the perfusion of the tissue. So These are some examples. You can see one of the patients with two monitors, a ventriculostomy in one side, an intraparenchymal monitor in the other side. And you can see the difference here. You see, for example, in the ventricle area that was monitored, that is the left side, you can see a patient with an ICP of 14, but if you go over the details of the waveform, P2 is over P1. That means that the compliance is affected even in presence of a normal ICP. And then in the other side, you have an ICP of 25, 25th, and the waveform is a little bit better than the other side, but probably is going to be moving into an abnormal parameter in some time. So how you can deal with patients that have all these big differences and how the compliance is affected. And then you can start going back to the traditional way of managing these patients. And most of these patients only have just one monitor at parenchymal level or a ventricle level, and you take decisions for all the structure of the brain based on just one number. So we start doing, as I mentioned, transcranial Doppler. We start seeing abnormalities also in these patients in the transcranial Doppler. So we identify TBI patients with abnormal ICP waves, loss of compliance associated with abnormal optic nerve ultrasound diameter, and with abnormal pupillary response, as I mentioned, decreased velocity, who had normal ICP values. So how we can call those patients? So after many of these observations, we publish these articles that we describe many of our observations, and we start, generating a hypothesis on how we can organize the concept in a way to move from the traditional aspect. And one of the early proposals was to call this condition the intracranial compartment syndrome. Why this was the idea? Because regularly when you have a compartment syndrome, it's caused by changes in pressure within an anatomical compartment. The compressions affects blood circulation and the integrity of the tissue containing the compartment, especially the nervous tissue. We were mentioning just examples where the perfusion was affected. It is a prerequisite to define this syndrome that the compartment must have limited elasticity, and we know that the cranium does not have elasticity. The compliance needs to be near to zero after a specific level of compression that reach the involved structures. Due to its anatomical and physiological characteristic, only certain areas of the body are more prone to develop this syndrome. So the most common we know are the extremities and the abdomen. But the intracranial compartment is included in a dural membrane of limited expansion, and it is divided in three subcompartments, two supratentorial, one infratentorial, that are also included in a non-elastic box or bone box. So it accomplishes all the general described concept for this syndrome. So therefore, the intracranial compartment fulfills the conditions to develop a compartment syndrome. And depending on the degree of tolerance, in this case compliance to pressure of each subcompartment, a change in volume or pressure of any of the contained elements, a subcompartment syndrome can progress to a generalized compartment syndrome. So considering all these previous concepts, an increase in ICP can generate a compartment syndrome with compression of nervous tissue and cerebral vessels, and the progress of this syndrome without treatment has the potential risk of reversible hypoperfusion or irreversible ischemia, generating temporary or permanent neurological damage. The exactly point was how much the ICP need to be increased in value. So we start looking also literature about this concept, and one of the early descriptions for something similar was published by Dr. Figaji, who was one of my co-authors in the paper that I just mentioned. He wrote a paper about surgical treatment of brain compartment syndrome in children in 2006. What he described at that time was talking about the very early use of the compressive surgery in pediatric patients, and he described that as how you decompress the cranium and you decompress the compartment. Also, there was this interesting book from 2021 when the members of the World Society of Emergency Surgery write a full book about compartment syndrome in all the areas of the body. And uh, uh, some of them were trying to organize the concept of compartment syndrome in the brain or in the cranium. So they define the pathomechanism of intracranial compartment syndrome, and they describe very well, and they say in this chapter, we will consider intracranial compartment syndrome a synonym of intracranial hypertension caused by an acute brain injury. So the original description was associated to intracranial hypertension, by definition, talking about a ICP value of more than 22 millimeters of mercury. But we cannot follow that definition because we understand that we were seeing patients with all those problems with very lower thresholds, like we show in the pictures, ICP of 12, ICP of 15, ICP of 18, and they were having the same issues of the description. Then they wrote another chapter in the same book about diagnosis and treatment, and they mentioned that the intracranial compartment syndrome is a condition that occurs when intracranial hypertension overcome the compensatory cerebral mechanisms. Again, they are based on the concept of intracranial hypertension, so we are talking about ICP more than 22 millimeters of mercury. They also describe that for treating these patients, the medical management should include several lines of treatment following a stepwise approach, escalating therapy, and how the maximum therapy need to be reserved for refractory elevated ICP. So we all know that when we talk about refractory elevated ICP, are generally patients that start going over 22, 25, 30 millimeters of mercury and didn't respond to the medical therapy. So the question is, these original descriptions were very interesting, but were not applicable to the real patients because we understand that sometimes, maybe at that point, we didn't have all the concept elaborated, but at that time, we were thinking that maybe some patients need to be start treated before arriving to a threshold of 22 millimeters of mercury. So describing a case of intracranial hypertension syndrome in patients with normal value of ICP is like describing a case of arterial hypertension in patients with normal arterial blood pressure. So you are not going to consider start a treatment for an arterial hypertension in patients that have normal blood pressure. So this concept is totally far from the classical concept of intracranial hypertension, as we identify patients with loss of compliance, abnormal ICP waveform, who has established an intracranial compartment syndrome with normal values of ICP and even sometimes abnormal values of oxygen, additionally to the loss of compliance. So the application of specific ICP thresholds to define intracranial hypertension has been considered a heuristic, being a proposal for solving a problem with a practical method without a guarantee of it being optimal, but being sufficient to reach an immediate short-term goal, in this case, to lower ICP. So the question is, again, if we go back, those numbers of the 22 millimeters of mercury, more than 20 millimeters of mercury, more than 30 millimeters of mercury, come from all these historical cohorts performed in the early years when they start using the ICP monitoring. So after organizing better the concept, we wrote this paper about the intracranial compartment syndrome. So we discussed that as a proposed model for acute brain injury monitoring and management. And the concept was not based on the ICP number. So it was not equal intracranial compartment syndrome to intracranial hypertension. It was something that even starts before, So we try to associate that according to the Lanfit curve analysis in 3 stages, where there are some stages where you can have normal ICP, and normal oxygen that are like the regular one, but then you can move to stages where the ICP can be normal, but the compliance is abnormal. And you can maintain, or you can still maintain normal level of oxygen. And then there are worse stages when you have abnormal compliance and abnormal oxygenation, and regularly in those processes, the ICP numbers goes up. And the difference there, as was originally shown in some of the Lanfit analysis, the pattern of the waveform changed totally from the second stage to the third stage. So in the third stage, the worst stages, we are seeing the pyramidal waveform of the ICP waveform. And on the previous stages, we see P2 over P1 that is affected compliance, but not in the worst situation. So when we start talking about this concept, was not like well understood. I was in many different countries presenting all these opinions and our hypotheses, and many people didn't understand what we were talking about. Uh, so then, fortunately, when we start moving ahead and working very hard with the non-invasive systems, especially in areas that do not have too many resources, we arrived to a point where we propose to do a consensus for uh, when to use and how to use this tool for monitoring patients when invasive systems were not available, specifically talking about TBI patients. So I remember we were in a global neuroactivity with Dr. Chiara Roba, who was an anesthesiologist and intensivist in Europe that works a lot at the time in transcranial Doppler. And we were talking with an African student from our course. And after being presenting or discussing some of these non-invasive tools, he asked us, he asked Chiara and asked myself and say, do we have like a specific recommendation for use this device? And we were, like, no, there are no specific recommendations about how to use those devices. So when we finish the class, we start talking with Chiara and say, we need to do a consensus. So we start working into this process. Fortunately, after some time, in one of the Euro-Neuro activities, Dr. Fabio Taccone was very supportive, and we obtained some funding for bring persons from LMICs and put together a group with half of people from high-income countries, half of people with LMICs that were using already many of these systems, and we put them together and established some recommendations. So this is how the intracranial compartment syndrome concept comes into a reality after all these years. Now we are going to discuss the relationship between that concept within the new framework of the Monroe-Kelly 4.0 paradigm and how they shift inside the new framework for neuroworsening. So we already talked about the Monroe-Kelly 1.0 and how it was criticized because the CSF originally was not described into the components or the dynamic components of this theory. Original, remember, we have the specific fragment here. They were talking about how you need to take out blood of the skull in order to receive new blood, in this case, arterial blood and venous outflow, to maintain the homeostasis inside the content. So after the evolution of the theory and after evolving with all this concept of the intracranial pressure, it was very clear, as we mentioned before, that there were dynamic components and there were static components. And the dynamic components regularly were the CSF, a very important component that is moving around the structures, also the arterial blood and the venous flow, and how these dynamic components are very important because as they pulsate, they also move from in and out the skull. The static component cannot get in and out of the skull. In this case, is the brain tissue, and this is how the dynamics maintain. So the harmony between the pulsation of the arterial vessels, they generate the movement of the CSF. They also relay the movement of the veins, and then the tissue is just moving around them. So because of this, there were some additions to the theory. In this case, we have some of the description here. In 2016, there was a more in-depth analysis of how the venous components of the intracranial pressures affect that. So they were describing how, for example, if you have anatomical abnormalities of the venous outflow, you can affect the response to the compliance. So if you have, for example, agenesia or some of the venous areas, or if you have, for some reason, a venous thrombosis, that area in that compartment will be affected because it will not respond in the same way that the other one. So this was very important moving into those concepts. The important aspect of how the venous system needs to work and how it affects the compliance aspects. Then in 2019, they centered a little bit more into the CSF, as was discussed briefly before. The two main dynamic components, the venous flow and the CSF, that were the components with very low pressure compared with the arterial flow. So we get into all these details and bringing back all these new concepts into the intracranial compartment syndrome. We understand that the syndrome was caused by a lot of tolerance or compliance to pressure gradients within the anatomical compartment. And this loss of tolerance can alter the normal dynamics between the components of the compartments, affecting blood circulation and the integrity of the tissues, especially the nervous one. So, therefore, the diagnosis depends more on the state of the compliance assessment to determine whether it is present or absent the intracranial compartment syndrome. And we understand that the pressure gradients can have variations and depends on the anatomical and physiological characteristics of the compartment, as was described by the venous system and also the CSF. If you have alterations in the CSF obstruction for some reason, either at the cisterns or either at the ventricles, you are going to affect the compliant response. So we can see here some of the examples of patients that we detect with very early affection of compliance, with almost sometimes even normal CTs, but total abnormality after a trauma in the non-invasive evaluation and sometimes even in the invasive evaluation. And what we start finding was that many patients after a trauma have conditions that affect the response of the dynamic components. I am showing here two examples. One patient that you see with a very almost normal CT after a trauma, but all the system were showing abnormalities, and even sometimes the GCS was low in this patient. When you see many of these patients and you are not monitoring them, you sometimes put, a brand over this patient and you say, this patient is a diffuse axonal injury, and that's it. And for many diffuse axonal injury, you just left the patient there, scheduled to do an MRI, and then do nothing. But if you start doing all this monitoring in this patient, we sometimes understand that the compliance is not working well. And the question is why? So it is a diffuse axonal injury, or is a patient that have a problem with the compliance because some pre-existing condition or something, and we are not seeing the whole picture. So sometimes these patients ends in surgical procedures, and we saw, for example, patients with a very bigger table inside the school. Like if you regularly go and evaluate the bone when you do a regular craniotomy, regularly the size of this bone is around 1.5 centimeters. And in some of these cases, we found patients with hyperostosis on almost 4 centimeters of the cranial bone. So that means that the compartment, it is reduced because of the hyperostosis. So you have less possibilities of moving the dynamic components in order to compensate that after a trauma. Or in some cases, we do venous studies and we see patients like in this case with an important thrombosis that affect the response in that specific compartment. And regularly, we never evaluate these aspects. We never measure the inner table. We never measure from the very beginning if there are some venous outflow problems in these patients. So what we were seeing is that all this integration of the multi-monitoring is allow us to give a red flag for some patient that say you need to study this patient very well and you need to follow very near that in order to take action before the patient decompensate. Because when you do nothing, sometimes these patients move from a very good condition to a very bad condition, and sometimes it finish in infarcts or something like that. And then you start looking in retrospective for what was the cause of the infarct, and you start looking for crazy things instead to understand that was the compliance that was affected from the very beginning. In this new process and advancing within this framework, we understand the role of the autoregulation. Autoregulation was originally described in 1969, but the studies of Niels Lassen, we now understand that the early description of Niels Lassen was in a model that is called the static autoregulation, because the model that they used for analysis were patients with perichronic arterial hypertension, either eclamptic patients or a hypertensive patient. So this is not how we understand now autoregulations in the acute settings. So what we see now is something that is called the dynamic autoregulation, and that's why it's very important to test as early as possible autoregulation in these patients. We understand that there are several ways of measurement autoregulation. We have invasive methods for evaluating that. Now we have all these many indexes that are becoming very famous, like the PRX, that is the correlation between 5 and 10 seconds in average of median arterial pressure and the intracranial pressure. We have many of these that allow us to understand if the patient is auto-regulating or not. And we also have non-invasive methods, so we can also evaluate some of the stage of auto-regulation either with transcranial Doppler or other non-invasive systems. So the most important thing here is that we understand that if a patient is not auto-regulating and we use the traditional medical approach, as you start increasing the median arterial pressure to try to compensate the ICP, what you're doing is the opposite. As much as you increasing the arterial growth, you are increasing in parallel the intracranial pressure. So this is very bad for your patient. So that's why it will be very important since the very beginning to understand the auto-regulation inside this concept. Another important concept was the evolution of the concept of brain edema. The traditional approach of the two stages of brain edema, the vasogenic one and the cytotoxic one, was originally described by Glatzo in 1967. Glatzo was a pathologist, and he described these two conditions and how they differentiate, understanding that the cytotoxic is a intracellular pattern, and the vasogenic is an interstitial pattern. So it's an extracellular one. So they differentiate in that way. Posteriorly to that, Jan Simar, who was Glatzo mentee at the University of Maryland, started moving around, but more in model of ischemia. And he described something that is the ionic edema, that is a transition phase between the cytotoxic one, the intracellular one, to the vasogenic one, especially when the blood-brain barriers become abnormal and it becomes open. So during that transition, there is a phase that is called the ionic edema. So he described how all these interacts with the blood-brain barrier, how it moves with the cerebral interstitial fluid and the CSF. Posteriorly, we all know the work of Dr. Aicherian describing the famous chief edema. That is a reversal process where from the lymphatic system at the subarachnoidal space, the fluid moves inside the interstitial tissue, generating more edema. And regularly, this is associated to an obstruction of the CSF circulation in the subarachnoidal space. So this is very common in patients that have post-traumatic subarachnoidal hemorrhage. And before that, the post-traumatic subarachnoidal hemorrhage was almost considered not enough importance. It was associated with higher mortality, but we never understand why this was associated with bigger mortality. Now we know that the post-traumatic subarachnoidal hemorrhage is one of the main causes of CSF chief edema, and if we do not do something in this case, like cisternostomy to clean the cisterns and washing the cisterns, those patients will have an increased trend to generate more edema that is not be able to treat with hyperosmolar therapy. That is our main approach for all the types of brain edema. And also they didn't respond also to steroids. So as we move into that, unfortunately, now we understand better all the issues related to the lymphatic system, how a new membrane that is called the SLIM divides the subarachnoidal space to move the lymphatic system and also to continue the regular flow of the CSF, and how the obstruction of this can generate an important, deviation of movement of the flow of the CSF inside the interstitium through the visual Robin spaces, and how this is something that have been existed for forever, and we never understand that until now. So the most important things here is that we are finding more and more new patterns or uh, uh, trends of brain edema that were not considered in the past. And because we're not considering the past, we never treat. Now we are in the process of doing a very specific description of this other process, that is the inflammatory response associated to the hem degradation in intracranial hemorrhage. We have read about this, especially in stroke patients, but we never go into the details of considering this a very specific type of brain edema. We have called this the hemolytic brain edema, and is totally associated to the degradation of the hem. So the way to treat this is to take out the blood in whatever compartment is inside the skull in order to decrease the hem degradation. We have some examples here. We have contusions, where they have the regular evolution to a pericontusional edema that is more associated to the disruption of the blood-brain barrier and turn into a vasogenic edema, but also not only for the intracerebral hemorrhage, but also for epidurals and subdurals. When the hem start doing degradation, they generate their own inflammatory response surrounding the tissue, so they can increase the vasogenic edema and they can increase the edema around these collections. So this is something important for the actual treatment of the patient, because at some point, if you detect abnormalities in the compliance and the only possible cause is a very small hematoma, what we never operate or something like that, maybe that will be a good, important consideration for minimal invasive surgery. There are areas like in China. We were with some colleagues in China, seeing how they, for many years, have been treating with minimal invasive system drainage many of these collections, and the patients do very well and evolve faster than patients that we do not interventions. So we start moving with this concept. Is still there. As I mentioned, sometimes people didn't understand that, but it would be important to understand that we have at least 7 different types of brain edema, and each one of these brain edema have a different way of treatment, and we never specified that. So we published recently this review about all these types of brain edema and how we can approach each one of them. And we are talking about this concept because these are the causes why in some patients you have abnormal compliance that is affecting even at some point the perfusion. Now, this is why we understand that when you start doing like all this big data analysis, like the analysis of the images of the tract TBI or the center TBI studies, there is a very specific pattern that is the one associated to higher mortality. It's very common. That pattern includes patients that present with subdural hemorrhage, acute subdurals, intracerebral contusions, and also post-traumatic subarachnoidal hemorrhage. Now we understand that this is the biggest risk for having mortality, because you are having a patient that have 3 different patterns of brain edema, and in almost all the world you treat that only with one intervention, that is hyperosmolar therapy. The issue is that when you treat all the types of brain edema with hyperosmolar therapy, you can worsen it, some specific subtypes. Like, for example, if you have a patient with vasogenic edema and you put mannitol or you put hypertonic saline, what you are going to do is to increase the pathogenic edema, you know. So this is why some patients arrive to a point when you say, oh, this is a malignant edema. This is not a malignant edema. What you are doing is you are treating the wrong edema with the wrong treatment and you are generating more problems. But now that we are in the possibility of to analyze in detail which type of brain edema is inside the school and sometimes how they overlap, you can focus better and personalize your treatment in order to avoid that type of abnormal response. So this is what we are looking with all these multi-monitoring analysis in these patients. Sometimes you can identify which compartments inside the school are working, which ones are not working into the dynamic process to compensate the compliance. And we need to go specifically to understand what is the cause. So all this was put in this paper that we call the Monroe-Kelly 4.0. That is how we move with all these new concepts and integrate the lymphatic system dysfunction, the autoregulation status, and the compartment syndrome inside the traditional concept that we already know about the importance of the venous flow, the importance of the CSF, and also the arterial components. And almost finishing, I want to highlight something that we just published recently. That is the evolution of the concept of neuroworsening. If we go over the last 50 years, the way that we define neuroworsening in traumatic brain injury patients is patients that are herniating. We define neuroworsening with abnormal clinical response that include regularly, motor affection, GCS decrease of abnormal pupil response. We all know that when we have abnormal pupil response of motor compromise and GCS dysfunction is almost always associated to brain herniation. And the other way to define neuroworsening is with imaging, and that imaging include midline deviation of basal system effacement. And we all know that when we have midline shift or basal system effacement, we are talking about brain herniation. We are talking about singular hernia, or we are talking about, uncal hernia. And that means that what we are doing right now is waiting for patients to herniate in order to define treatment. So now taking all these concepts of the Monroe-Kelly 4.0, the intracranial compartment syndrome, how we can detect very early problems in a compartment management of the compliance, we really need to shift the concept of neuroworsening. And we just recently proposed with the group of experts a stratification process for the neuroworsening concept. What we propose is that there are some patients that have anatomical conditions like the ones that I show with the hyperostosis, or the ones that can have previously to a trauma like a venous outflow problem, or patients that have systemic conditions that are associated, to problems to maintain compliance. There are some systemic conditions that have been associated to that, and that type of patients, we consider those the high risk phenotype. So when we have a patient with TBI, the first thing that we need to do is that patient a high risk phenotype? Because if that patient is a high risk phenotype, patients that have craniosynostosis without treatment, patients that have, this type of hyperostosis, patients that have all these venous problems. So those patients for sure will have a higher risk of deterioration as early as possible. So we need to understand that these patients need to be followed very strictly, either with non-invasive or with invasive or combined systems. As soon we detect in all the patients, not only in the high risk Y, but in all the patients, as soon we detect abnormalities in all these parameters of neuromonitoring, then we enter into something that is proposed to be called subclinical neuroworsening. Is subclinical neuroworsening because they still do not herniate. They are starting to have the problem, but they are in a process of, if we do not do nothing, they are going to herniate. So we can start intervening many of these conditions before the patient herniate. That means that we are going to be able to save more brain tissue, and do not expect a patient with a very bad outcome or very disabled because we act very late. And then the final stage will be the established neuroworsening. That is the regular one that we all know and have been working for the last 50 years or more, is the patient that clinically or imaging herniates and deteriorates. So this will be a game changer if we start using this process, understanding that we need to be more precise and more personalized in the treatment of TBI patients. So, in order to finalize, the idea is to present a new framework for surgical decision making based on all those concepts. So, we just recently published something that was like the preliminary version of how we can integrate all these concepts, including all the neuroworsening new concepts, and then define which kind of surgery does the patient needs. So, there is a combination of all these diagnosis tools that allow us to understand better, according to the degree of intracranial compartment syndrome, how aggressive we need to be with therapy. For example, if we are in a very early stage, maybe that patient only needs, a CSF diversion. It will require a ventriculostomy, or in some cases, it will require a cisternostomy, especially when they have like this post-traumatic suprarenal hemorrhage. And maybe that will be enough. The only way to do or to understand if that will be enough will be continue monitoring these patients. But if there are patients that are in a very late stage, then those patients need to be treated with more aggressive procedures, like a craniotomy, an expansion craniotomy, or the patients that already have like oxygenation problems definitely are the patients that will be requiring decompression, the full decompression. So all these obviously need to be tested in clinical trials, but we think that maybe this will allow to decrease the heterogeneity for defining treatment in TBI patients. The worst scenario now is that many neurosurgeons are taking care of these patients around the world, and then define what type of surgery that the patient needs based on very, very different parameters. And most of these parameters are regularly affected or generate some bias associated to non-objective issues. For example, we all know the different guidelines, we all know the different consensus, the different protocols that have been proposed. But if you are very tired and your patient arrives very early in the morning, sometimes you delay the surgery because you are tired or because you are going to have a scheduled surgery or many other reasons. And the reason that delay the surgery is not really because the patient need to be delayed, is because the surgeon decide to delay because of some other issue. So when you tailor the interventions in a better way, maybe you can understand very early if you need to do a minimal procedure or maximize the procedure. And maybe you can decrease all these bias that you have when you are in the decision-making process. These are the two big studies that we are going to start soon that will integrate many of these concepts. This one, the first one is called the E-Space TBI Study Protocol. That is a comparison between decompressive craniectomy versus expansion craniotomy or hinge craniotomy with a very specific device. But the interesting thing is not just the surgical procedure per se that will be evaluated, is because in the protocol, the concept of intracranial compartment syndrome and the use of all these non-invasive technology will be part of the management of the patient since the arrival at the emergency room. So it will generate studies that will, for first time, using many of these concepts in order to define as early as possible the surgery, and then you can decide which type of surgery are you going to do. The other protocol is associated to the evaluation of a locking system for ventriculostomy. We all know that most of the main complications for ventriculostomy in many places is that it is displaced, it is moved, it generates more infection. But with this type of systems, the idea is to test if they can reduce the complications and also define patients that just will be enough to treat with this type of minimal intervention. So when you decide your next ventriculostomy in your trauma patient, you maybe need to be sure if this will be enough for the patient, or if you are doing that because it will be the easy approach or is the faster approach and you need to do something else, or really because it will be the approach that your patient will need, not only for monitoring, but for treatment. We are going to publish soon a consensus with the World Federation of Neurosurgical Society Neurotraumatology Committee when we define how are the better way to use this system. And it's clear that now the ventriculostomy, understanding that was for many years the regular system to use for monitoring ICP, now is maybe not the best approach because we have all this availability of intraparenchymal catheters, and we understand for all these type of different concepts of brain edema and other issues that draining ventricular CSF is not always the best approach. As we know, maybe a cisternostomy could be a better approach in some patients that do not require to have the ventriculostomy. So there are so many things that can be discussed around this topic, and hopefully we are going to publish soon the recommendations. The cisternostomy, there are many people that think that this is enough for all the type of cases. Now we understand that it's not. There are some patients that will really require this, and in this case, the idea is to avoid the CSF-GV edema, and the main cause of CSF-GV edema are regularly patients that have a lot of post-traumatic subarachnoid hemorrhage. So maybe those are the patients that will gonna beneficiate the most, especially if they have abnormal patterns in the non-invasive or invasive monitoring. Understanding that decompressive craniectomy have a lot of complications, especially CSF fistula or also infections. So it will be very important to understand that sometimes we don't need to have a full decompression, and maybe just an expansion of the cranium will be enough. But the only way to understand that will be doing monitoring before and after the procedure in order to check if this will be actually enough. Not controlling this just with a CT image. The thing is that we need to move to define everything in trauma just with a static picture that is the CT, other than understanding the dynamic inside the school with all these monitoring tools. And definitely there will be, or there are going to be some patients that we're going to require a full decompression process, but the idea is to select better these patients. So again, thank you so much for this nice opportunity to share our experience. This is the group of our trainees that have been working in this fellowship program that we have internationally. Um, and we want to invite you to the International Neurotrauma Society meeting that will be hosted this year in Cartagena, Colombia, from October 25th to 29th. We are going to have several pre-congress courses totally focused on trauma care, either for spine injuries or for cranial injuries. And we welcome you all to exchange with the Latin American community all the important aspects of the experiences all around the world. We are going to have many people from many regions, and we are going to share a lot of um, the experiences that are coming into basic science and clinical science for managing neurotrauma patients. So again, thank you so much. Thank you to Dr. Noor, and hopefully this webinar will be of interest.
Thank you very much, sir. It was an amazing talk. Like I have already mentioned, it's a great pleasure to have you here, sir. Thank you very much. I know that you have just reached Ecuador, and I'm really, really grateful to you for spending time, even after such a long travel. Professor Andre, I think I have made you the co-host. Can you? Hello, sir.
Hi, Noor, how are you? You hear me well?
Hello,
Well, you hear me?
sir. Sir, we can't hear you.
Did you hear me now? Can you hear
Yes,
me?
yes, we can hear you. Thank you very much,
Okay.
sir. Thank you. Sir, first of all, thank you very much. I know it has been a really tiring journey for you that you have been traveling all the way and still this spare time. Thank you very much. Your dedication is really impressive, sir. Thank you so much again.
Thank you, Noor. No, I think this is a very important scenario to discuss and present some of these ideas that we have been working on. And hopefully we can promote, the paradigm shift to start moving ahead with different interventions, changing the paradigm that we have been doing for the last 50 years or more.
Yes, sir, exactly. Sir, your talk is really phenomenal, and I really genuinely believe the way that you have redefined the intracranial compartment syndrome and neuroburstening, it's really, really a game changer. And with all this comprehensive physiological, framework that you have proposed, it is much more beneficial for us to go for to actually see what's the predominant failure mechanism, to go for the right, treatment paradigm, and also, sir, the way that you have actually proposed the proactive recognition rather than acting on a catastrophic decompensation is a very huge step, and the way you have actually identified and emphasized on the subclinical duration is really, really impressive. Sir, we have got plenty of questions for you because your talk has been really, really, really amazing, and I think it's really a paradigm change the way you have shared, and I had the pleasure of sharing your paper with my colleagues and friends all over the internet. So they all have, I think, have a good idea, but I will repeat it again. So again, sir, I believe that can we, sir, I think we can, would you like to take a couple of questions? I know you are at the conference right now. Sir, there are a couple of questions in the chat box. Would you like to take them? I think that many of the things that you are very nicely defined, but there are a few things that people really wish to ask. How do you correlate with the high ICP with high intraspinal pressure, though in the two different compartments? If you, however, are faced with this scenario, how would you approach such a patient with a high ICP and a high intraspinal pressure?
So I think we are in an interesting time where there are some studies. Actually, I think you are familiar with the discus study that it has been performed at the University of Oxford, when they are extrapolating the concept of measuring ICP for the intraspinal pressure measurement. So I think we are going to be understanding better these interactions. But definitely what we evaluate with the non-invasive systems actually in all of the compartments is that it actually belongs to the compartment that we are measuring. So for patients that have like specific patterns of TBI, and we early detect alterations of the compliance through this non-invasive system, definitely we need to believe that something is happening inside that compartment with the interaction between the dynamic and the static components. So we are not yet in the way of measuring specifically the interspinal pressure, but there are trials ongoing that will allow us for future to understand that interaction better.
Incredible, sir. And I'm just going through quickly. There's another question in terms of treatment of the ICS. Would the treatment be more biased on surgical or medical intervention? I suppose it would have to do also with the cause itself. And sir, the second question is, do you rely more on images or on the GCS score mainly in the selection of compliance and ICP bilateral placement?
So definitely the TBI is a condition that in the most severe cases, it will require surgical management. And as I mentioned in some of the meetings that we discussed this topic at the level with the intensivists and the critical care physicians, the first stage for the good critical care is the surgery. The worst thing that we can have is being in a presence of a patient that have surgical indications. It was not operated, and they move the patient to the ICU, waiting for save the patient just with medical management. That's something that we need to take out from our heads. And what we need to decide is which patients need to be operated as early as possible. And with this new framework of the new definitions of neuroworsening and the new approach of the intracranial compartment syndrome evaluation and the Monroe-Kelly Doctrine 4.0, we definitely are moving, as I mentioned in the last slide of this lecture, to the possibility of link that with the very specific type of surgery that we need. Possibly for the very early cases where the results of the non-invasive evaluation tell us that the case is not severe. For example, one early identificator of severity when we perform, for example, optic nerve ultrasound is to have a value over 7 millimeters. When you have a value over 6 millimeters, something is happening in that compartment, but when you have a value over 7 millimeters, this is really bad. So when you have all these different trends, for example, when you have in a pupillometry an index, either the QPI from the European system or either the MPI from the American system that is below 3, is almost correlating with a herniation process. So there are going to be specific numbers or targets or thresholds with all these non-invasive systems that together will allow us to understand the severity of the condition. Now, we didn't speak too much in this talk about biomarkers, but if we correlate also with the biomarkers level, definitely we are going to understand that there are going to be patients that require more aggressive management, in this case, surgery, as early as possible in order to correct the problem. So I think we are going to move in that direction soon. We need to start, understanding these concepts in order to start moving the field. And this is a really good opportunity to exchange with many of the neurosurgeons around the world that are actually working with these patients. I think the other question was related to the bilateral invasive monitoring. So definitely, when we start combining the system, for example, we have a patient that arrived and we do the non-invasive approach and we detect that is an area that is increasing the problem. We don't work on one single measurement. We regularly take decisions over different measurements, different periods of measurement. If you go over the Brussels consensus, they recommend that for severe cases that you are using all these non-invasive devices, you need to measure at least every 2 to 4 hours all the parameters. Or if your patient is not doing that bad, you can measure every 6 or 8 hours all the parameters, and you look the trend. So if the trend is going worse and worse, maybe that patient requires invasive monitoring. So you definitely start the invasive monitoring in the area where the non-invasive is worse. And then if you do whatever procedure you need to do, I always recommend that, for example, if you do a decompression in a very bad case, you need to monitor the contralateral side, either with non-invasive or with invasive if you have the access to the tools. And then also, if, for example, we are working in a patient that have already a ICP monitoring through a ventricular catheter or through an intraparenchymal catheter, and we decompress that side, we never take out the catheter. This is something very important that is a very common situation, that you take out all the monitoring systems in order to do the decompression. We keep the monitoring in place, and then if something is happening with the other side, we need to monitor also the other side. Or, for example, if you use that is going to be one of the recommendations for the new consensus that I mentioned for the World Federation. If you are, for example, monitoring a patient or you are treating a patient with a ventriculostomy for any condition, because the patient have a post-traumatic hydrocephalus or because the patient have a intraventricular bleeding, then you need to use also a monitoring system for that patient that regularly is not the best approach, the ventricular catheter, because we all know all what happened with those ventricular catheters. They obstruct, so they start, not working properly. So the value that, and the waveform specifically that come from these catheters sometimes is not the best. So when you treat patients with ventriculostomy, one of the recommendations will be that if there is a problem that you expect to have a problem with the compliance,
and you have the invasive tools, you can use intraparenchymal monitor in the contralateral side. So you will finish with a case that you have two catheters in place. So this is something that you will learn over the time. And as most cases you treat, then you can start identifying which patients are going to need bilateral monitoring.
So thank you very much for your very, very elaborate and very, very insightful answers, because I think that your answers even are very, something which is going to be to benefit a lot of patients who are a lot of attendees who are going to see the recordings, because everyone is asking for your recording. Your lecture has been so amazing and so much insightful, and I have been receiving a lot of messages for you, sir. I believe that we have gone through all the all those almost all the questions. There's just one last question. Are there precautions needed in correcting the compartment syndrome as a scenario in other parts of the body cause rebound effect with correction? So is there any precaution that is needed in correcting the compartment syndrome? Sir, I know you are in the conference right now, so I believe that we need to wind up early.
Yeah,
Well,
no,
we
definitely
actually
there
started your time.
are.
Yeah,
No,
I know
definitely.
this.
Yeah, no. I think this concept of the multi-compartment syndrome, especially
Yes,
in patients with polytrauma, exists, and definitely there are
yes.
interactions. You know that there is a study going on in Germany for laparotomy for managing ICP. We are going to have soon the results, and definitely is an intervention that has been described in some cases as something that decrease the pressure over the general big veins of the body, and also decrease at some point the ICP. So this multi-compartment syndrome exists, and we need to take consideration of that and how it integrates into these concepts.
Thank you very much, sir. I'm really sorry for taking so long,
Yeah.
and thank you very much again, sir, for sparing your time from your very jam-packed schedule, sir. I'm so deeply obliged to you, so grateful to you from on the behalf of all the attendees, and thank you very, very much, sir, for coming today. We are taking so long from you, sir. Thank you very much, sir, and I hope will have a very wonderful conference, and everyone will be so lucky to listen to you and learn from you.
Thank you, Noor. Thank you to everyone, and thanks for being here, listening all these concepts. Thank you so much.
Thank you very much, sir. Thank you very much for your contributions. So thank you everyone for attending today. The recording will be available on my YouTube channel, and I have shared the links to download your certificate of attendance. So please do go through that link, and also you are cordially invited to my next talk with Professor with Professor Victor Pereira, and he's the one who actually did the world first tower robotic. So you don't miss this talk, and he was one of the person who designed the diet of the Artemis 2 mission, the astronauts of the Artemis 2 mission. So please do. He's such a visionary. Don't miss his talk. He is um, and he is one of the he was one of the visionaries. So he has just made a very big milestone. So please don't miss his talk, and to come on 18th May 2026. That is a day after tomorrow. That's on this Sunday. So please do attend that talk. It is one of the most important talks I believe I have ever myself scheduled, like today's talk, which was very phenomenal. So just published okay. Oh sure, I just shared the link, and just a minute please, just a minute. It's um and if there is anything that you wish me to arrange a webinar on, please do share it with me, and I will be really happy to share you all those. I will try my best to find the best speaker. I believe that you have enjoyed today's talk, because I do think that is a very phenomenal talk, and a total paradigm shift with a lot of concepts that we have to think about, and it is no more the thing that we used to think. And I'm really happy that I have actually written something very similar recently. You might be able to see it in the papers very soon. And we have to think about so many things that neurosurgery is no longer that we have to go with the modern concepts, and we need to think more in order to have a better to provide better results. Oh, hey, so here's the link to the next conference on which will be held this Sunday with Dr. Vaisha Pereira. So please do attend it because this talk is really, really important. He has done, like I have told you, the first robotic, back to me, and he while he was not around, and it's a huge step. So thank you everyone for joining, and I hope to see you again tomorrow, the day after tomorrow, and have a wonderful day. And I hope that you all have seen the Neuromics, my new project of the comics, which I will elaborate on 18th. And I'm also going to give you a free copy of one of my Neuromics on May 18. So please do attend on May 18, and I will be giving out my free copy. One of the comics is totally free for my wonderful friends who the attendees who are attending the webinar. So again, thank you so much for joining. The recording will be available. So have a wonderful day. Have a wonderful rest of the day. Happy Friday.